And then I'm excited to introduce our topic today. So, our topic is what if I don't qualify for transplant? This topic is one I'm excited to talk about as I've gotten several questions about this recently from members in our community. After our recent webinar on bone marrow transplant, I had a couple of our members reach out to me and let me know that they were told that they don't qualify for transplant. That can be an incredibly difficult piece of news to hear and can leave you with a lot of questions and worries about what this means for you and your treatment moving forward. Whether you have found yourself in this position or you're tuning in today on behalf of a loved one or a friend, I hope today's webinar provides you with the information you came looking for. Now for this in-topic presentation, I chose an awesome presenter. Let me take a moment to introduce her. Dr. Ragon is an associate professor in the Department of Internal Medicine at Wake Forest University School of Medicine and director of hematology operations at Levine Cancer Institute in Charlotte, North Carolina. She joined the leukemia division at Atrium Health Levine Cancer Center in 2017 as an adult leukemia and transplant specialist. Her clinical expertise is in acute leukemias, myeloid diseases, allogeneic transplant, hereditary hematologic predisposition syndromes, and bone marrow failure syndromes. Her research is focused on utilizing protein and gene exploration to identify biologically informed therapeutic targets for myeloid malignancies. She aims to find markers for response prediction, toxicity limitation, and to optimize currently available and novel therapeutics. Dr. Ragon has presented and participated in our HealthTree University online educational program several times, and through interviews and her answers to questions, I found her to not only be incredibly talented at what she does, but also empathetic and in tune with the needs of her patients. I'm excited to have her here today, and with that, I'm going to turn the time over to her.
Okay, can you hear me and see my screen? Let me.
Yes.
Okay, wonderful. All right, thank you. That was a very kind introduction. And I'm very excited to discuss this topic with you all today. Just in full disclosure, originally I was just going to talk to you all and answer questions, but I did prepare some slides to hopefully put this in context. But honestly, this is such a personalized question that I think if there are questions that come in as we go, I look forward to answering them at the end of this formal presentation. So, we should be talking about living with acute myeloid leukemia. What if I don't qualify for transplant? So a few disclosures. I am a leukemia physician and I'm a transplant physician. So I had to try to make this not a talk about access to transplant and how maybe we're not qualifying for transplant. This is going to be focused on the patients who really can't go to a transplant, but I'm going to add some plugs in there to make sure that we're getting the right evaluation for you. So some other disclosures, which may or may not be relevant. I don't plan to go through these very much, but big picture. If you come into my office, this is a conversation I have every single day. Acute myeloid leukemia is a passion of mine. Taking care of patients with this disease is everything to me. So when I start talking about this, I think it's important to go over the goals of treatment. And I try to simplify it because it's a really complex illness, as many of you know at this point. So the goals of treatment from my perspective are, number one, we have to get rid of the leukemia. What we know is living with active leukemia really impacts the quality of life and makes you feel really bad. So if we can get rid of the leukemia, typically that improves the quality of life and makes you feel better. But as you may know, acute myeloid leukemia is tricky in that once you get rid of it, you have to do something, number two, to keep the leukemia away. So our first goal in treatment is remission or getting rid of the leukemia. And the second goal is how do we consolidate that response and try to keep the leukemia from coming back. And just to put things into perspective, you may know these statistics already. AML is a relatively rare cancer. It only represents about 1% of all cancers that are diagnosed. But for those of us who are specialists in this is all we see and treat. So obviously it feels quite common. And for those that are going through it, it's all you can think about, right? And so I hope to provide a little bit of hope for those of you who perhaps don't qualify for transplant for one reason or another. And just kind of let you know in general, for those that are being considered for transplant, only about 18% of all adult patients who have AML actually get a transplant. That's a higher number for those who are less than 70. About 40% of patients who are less than 70 years old will go on to a transplant in one form or another. So we'll go through that a bit. So in thinking about our two goals, get rid of the leukemia and keep it away, how do we put that into context? So how do we reach these goals? And what are the things that we have to think about for any individual person in order to achieve these goals? And what is the journey going to look like? So you may have heard about these risk categories that we use to try to put patients into a bucket of how difficult or challenging or how easy it might be to achieve the goals that we're aiming for. So we have these three groups of patients. AML is a very heterogeneous disease. There's different phenotypes for any one person that's sitting in front of you. And some of the characteristics of the disease can help us determine what your likelihood of response to the treatments we offer is. So these risk groups include three risk categories, and I'm going to go over them high level. For those of you dealing with AML, you probably know which group you fall into, but this is an important foundation to understand when you're walking through your treatment journey. So we have this group of patients who have these molecular markers that fit into the core binding factors. That's the translocation 821 and inversion 16. These are patients in the favorable risk group because they are known to respond very nicely to chemotherapy, and that's intensive chemotherapy. And these patients can be cured by chemotherapy alone. So just to keep this in context, not every person needs a transplant for the option of cure. There are some where chemotherapy alone can do it, but it is intense chemo that we have to offer. So that includes this favorable group with the core binding factors, patients with NPM1 mutation and CBP alpha. That's a small minority of patients, of course. Only 15% of patients will fall into the core binding factors. Everyone else falls into these intermediate risk groups and these adverse risk groups. So these are the groups where I think the question about whether you qualify for a transplant or not are important, because what we know about folks in these groups is that chemotherapy alone is unlikely to cure you of your leukemia. Chemotherapy can be used to get you into remission and potentially to keep you in remission, but may not give you that opportunity for cure. Of course, what is cure? What does it mean? We're not going to get into that, but I think it's important to understand if you fall into one of these groups, it might be a little tougher of a journey, but it's our job to find a successful way forward. And there have been sort of revolutionary improvements in AML care where we're focusing on these risk groups. So what's the phases of care, the continuum of care? You may all know all about this, you may be expert in it, but I think it's important to kind of rethink about this when you're thinking about your treatment journey. So when I first meet a patient, I have to walk them through what the phases of their treatment journey will look like. So that first phase of the journey, that's our induction. So the first treatment to try to get the leukemia to go away. Our goal is to reduce the leukemia burden to less than 5%. It's a very arbitrary number, but we know that if we can get it to less than 5%, we call that a remission. And that's important for long-term outcomes. In this induction group, we have what we call intensive chemotherapies. These are chemotherapies that have high risk of side effects, often are given in the hospital, and are usually tolerated better by younger patients. And that's just because our organs might be a little bit fitter, our overall physiology might be a little bit fitter. And then we have a less intensive treatment group, which I'm going to go through extensively, because the less intensive treatments are what have revolutionized the care for folks who may not qualify for a stem cell transplant. So getting the leukemia to go away, that's handled by your induction, okay? The next phases of treatment are how we keep the leukemia away. So I like to be very kind of, general terms about this. I think about leukemia as a bucket full of water. The induction, that helps you dump the bucket out, right? Just get it out of there. But you still have water droplets in the bucket. So the consolidation phase is how we wipe the bucket clean, all right? And that eliminates any residual leukemia that's left behind after your induction. So sometimes this consolidation is high-dose chemotherapy. So in that favorable risk group, these are the patients where you can use high-dose chemotherapy, and that might get someone to cure. Consolidation is also where I put transplant. So transplant is one of the measures that allows us to give high dose chemotherapy with a stem cell rescue. So it allows us to wipe the bucket clean. All right. Now we have this fantastic new phase of treatment, and this is especially important for folks who can't go on to transplant, that we call maintenance. So goal number 2, keep the leukemia away. So once you wipe the bucket clean, how do we keep the leukemia from coming back? So one type of maintenance is having had a transplant. There's an immune surveillance effect that allows it to maintain activity against leukemia. But if you can't have that, we now have maintenance drugs that are approved. So chemotherapies that you can continue as long as it's working for you and as long as you're not progressing, that help extend survival. They may not get you to that word cure, but again, cure is such a relative thing. My goals for patients who can't make it to transplant is, how do we help you stay alive without leukemia with an improved quality of life? Because remember, the presence of active leukemia diminishes your quality of life. So if we can find a therapy that helps the leukemia go away without harming your quality of life significantly, that's wildly important, because we talk a lot about survival and extending survival. Of course, patients want to be alive, but we want them to be alive with some life quality. So we're going to be talking more through that as we go along. So just a brief slide, because as I said, I'm a transplanter. So I just want to make sure everyone is clear about why they don't qualify for a transplant. The access to transplant has increased tremendously. There are reduced intensity regimens. Age itself is not an absolute contraindication. So here at LCI, we've transplanted someone up to the age of 80. He's 86 years old now, and he's doing great. So it's not just about age. It is about other comorbidities, though. We don't want the transplant itself to harm you or to potentially take your life. But that's our job with you, is to try to understand what your priorities are, what your actual fitness is, and whether or not you can tolerate the new era of transplantation. The other thing that's important to consider is, are you in that group of patients who could be cured with chemotherapy alone? And if that is so, is it possible for you to get that intense chemo that's required? Transplant is no good unless you get into remission. So that induction step is always still very important, and goal number 1 remains, right? We're also able to find a donor at more than 95% of cases. So that is no longer a barrier like it used to be. And then you have to have a really good social support network in place. I think, as you all may know, taking care of or caring for family members or friends who have acute myeloid leukemia or living with it yourself, it's a full-time job and it requires a big support network. So just keep in mind, if you've been told that you don't qualify for a transplant, make sure that that was a really informed decision. And if you've made that decision for yourself, that's absolutely fine. That actually helps us formulate a plan for your treatments going forward. So if you say, no way I'm having a transplant, that's absolutely fine. It's our job to give you a plan that makes sense for keeping the leukemia away long term. So here's a little bit of the hope that I was planning to mix into this talk today. There have been so many approved therapies for acute myeloid leukemia in the last decade. Prior to that, there was pretty much very little for us to provide in the way of approved treatments. But we are in the era of targeted agents, which is helpful, especially for patients who can't go on to transplant, because we have drugs that can potentially be tolerated long-term and can maintain these remissions long-term. So the most recent drug approval was one of our FLT3 inhibitors, quizartinib. And in the next slide, I'm going to spend a long time kind of going through what it looks like for patients who won't go on to transplant or who don't qualify for one reason or another. But this is just to show you that we have a lot of new approvals, and a lot of these approvals are actually in folks who wouldn't have qualified for transplant. Many of these clinical trials were in patients over the age of 65 or 75. And that's where the survival benefit was shown, was for older patients who weren't fit to receive intensive chemotherapy. And these targets really made a big difference in their care long term. So this is where we're going to sit for a long time, and we're going to walk through perhaps different clinical scenarios to help you think through what if I don't qualify for transplantation. So bear with me as I walk through this, because remember, when I meet any individual patient with AML, I already know their specific disease features and how to formulate a personalized plan of care for them. So to cover it globally, this is, a full-time job for me, and I'm going to try to consolidate it down into maybe 5 minutes. And if you have a specific case you want to walk through later, I'm happy to do that. So we're going to start at the top. And this actual figure was created by Dr. Courtney DiNardo and Andrew Way. They did a publication that kind of summarized the new agents in clinical practice for AML. Dr. DiNardo is a huge mentor of mine, so many thanks to her for creating this slide. And it might look a little busy, but I'm going to guide you through it. So if you look over on the left-hand side, you can see these different categories that include fit for intensive chemotherapy or greater than 75 with comorbidities. So we consider the greater than 75 group the patients who may not be able to receive that really intense chemo because the risk of the chemo is greater than the benefit, all right? And that could be someone who's 40 years old. If someone is 40 years old and let's say they have a kidney condition where they can't get some of these higher intensity chemos, we have to think about these less intensive therapies for these patients. So I'm going to walk you first through what it looks like if you can receive intensive chemotherapy, but for some reason don't qualify for transplantation. So again, the core binding factor, that's that favorable risk of patients. The thing that has been shown to cure them is intensive chemotherapy with a monoclonal antibody called gemtuzumab. So, over 65% of patients will go on to survive this treatment and be cured without transplantation. That's why there's no maintenance arm here. If you're in this older than 75 group or you're just not fit to receive intensive chemo and you have a core binding factor leukemia, the good news is you'll probably respond to less intensive treatment, and you may respond long-term to indefinite less intensive treatment. But we're going to try to do everything we can to either give you less intensive treatment followed by a reduced intensity transplant, just because we know that your likelihood of surviving long-term is very good. So then when you walk down, you see this FLT3 mutated group of patients. So about 30% of patients with AML will have a FLT3 mutation. For those of you that have it, you probably know all about it. But FLT3 mutated used to be a very high risk group of patients until a very targeted group of drugs called FLT3 inhibitors came along and changed the game, right? Revolutionized the care for patients with FLT3 mutations. So currently, if you can tolerate intensive chemotherapy, you would go ahead and get the intensive chemo, which is our standard, typically cytarabine and daunorubicin 7 and 3, along with a FLT3 inhibitor. Like midostaurin is one of them. We now have quizartinib approved as well. And for those that can't go on to transplant, the good news is these trials were designed in such a way that they allowed for maintenance FLT3 inhibitors, and these are pills that you can take daily. Midostaurin can be given twice a day. Quizartinib is a once-a-day medication. And they allowed for patients to go on to receive maintenance therapy. So midostaurin you can take up to 1 to 2 years following your chemotherapy. Quizartinib you could take up to 3 years. And I'm going to show you a slide where even if you don't go on to transplant, if you're able to stay on this FLT3 inhibitor, your survival is extended. And again, most patients were without leukemia, and being without leukemia generally means you have a better quality of life. If you keep walking down, we now have an agent called Vyxeos or CPX-351, which is a liposomal form of daunorubicin and cytarabine. And this is really indicated for folks over the age of 75. It was a subgroup that benefited most, and those were patients who were older. So although you may not be fit for something like 7 and 3, CPX is, in my opinion, a really nice option. It's not less intensive, if you will, but we can generally get patients through it pretty well. And if you go on to receive CPX, you can either receive consolidation with a bit more CPX, or now we have an approved agent called oral azacitidine, or Onureg, that can be used for maintenance for as long as you're tolerating it. and it has been shown to improve survival even without going on to a transplant. So we're going to talk more about oral azacitidine because that's really important for those who've received a remission and need some way to maintain their remission without transplant. And then essentially any other patient who doesn't have a target in that space, intensive chemo, if you're fit, maybe with gemtuzumab. But again, we now have this oral azacitidine maintenance option. And when I go through the trial itself, we'll spend a little time there and go through the risk benefits of that. So probably we'll walk down now into the less intensive group. So patients who are over 75 or have other comorbidities. My guess is if you don't qualify for a transplant, this might be where you sit or where you fall in terms of the chemotherapies that have been offered to you. Importantly, we're going to go through the VIALE-A study, which is a study of azacitidine and venetoclax, which has revolutionized the care of patients over, really, patients in general. It was designed for patients over 75 years old, but we believe that it might be useful for patients of any age, okay? So as we walk through the less intensive groups, we still use the molecular characteristics of your disease to determine what treatment is best for you. So important to keep in mind, because I didn't share this at the top of this lecture, if you will, but azacitidine is a hypomethylating agent. So this is a less intensive chemotherapy. It's kind of an epigenetic regulator. So if you think of the bone marrow as just being really messy, azacitidine just goes in and cleans it up. For those of you who may be on it or have known patients to be on it, it is generally well tolerated. The side effects mostly come from the fact that azacitidine takes the good with the bad. So folks end up with low blood counts, and that causes fatigue and sometimes bleeding, sometimes infections. So azacitidine used to be all we had to offer folks over a certain age or folks who couldn't tolerate intensive chemo. And prior studies did show that if you gave someone azacitidine versus anything else, that there was an improvement in overall survival, there was an improvement in quality of life, but it wasn't that long-term survival that we really would want for patients. So then along came venetoclax, and if you're someone with AML or know someone with AML, you've probably heard of venetoclax. It's a BCL2 inhibitor, it's a pill. It works in what we call the apoptosis pathway. And when it's combined with azacitidine or any of azacitidine's sister drug like decitabine, it has been shown to really improve overall survival. And this addition to our sort of backbone of azacitidine has really changed the options for patients who don't qualify for transplant. It's an important treatment mechanism for those that we can't consolidate with a transplant, okay? So if we start kind of at the bottom of this image in patients who don't have a targeted option or a targetable mutation, azacitidine or HMA is for hypomethylator, that's azacitidine, plus venetoclax or something called low-dose-cytarabine. This combination is absolutely important for patients who can't tolerate intensive chemotherapy. And unfortunately, this treatment is not curative, but it can be tolerated for a very long time, and it can help patients respond for a very long time. We have data now on long-term survivors on azacitidine and venetoclax. And, you know, we work as physicians to try to space the regimen out. As it starts, it's 7 days of an infusion or injection of azacitidine, along with a pill venetoclax that's given for 28 days or 21 days, sometimes 14 days. And that's indefinite. So you get it month after month. But if you're responding, we try to space it out so that it's a more sustainable regimen, so that it's not all you're doing all the time. But I have folks who've been on that regimen for years. And in fact, it's so successful that now we're starting to learn about patients who came off and actually have treatment-free remissions. So azacitidine and venetoclax are wildly important for patients who can't go on to transplantation because it's the one of many ways that we can help keep patients alive and without leukemia. When you start to look into the molecular features of the disease, so we have this group of patients with IDH mutations. That's about probably 20% of patients have an IDH1 or 2 mutation. And the great news is We have targets for that. So pills. So ivosidenib works against IDH1. It can be combined with azacitidine. You can get that treatment up front and you can stay on it for as long as it's working. In fact, it works as a single agent too, but we often will combine it to give you the best benefit and the best chance of a remission. The same goes for enasidenib that works against IDH2 mutations. And the good news is that these drugs are generally well tolerated, so patients can receive them for a very long time. Ivosidenib and enasidenib are also very important for folks who might have had a remission from something like azacitidine and venetoclax, but relapsed or progressed, because they can be used as single agents in the relapse setting. So that's what's shown over on this side of the slide. And then now we have our NPM1 mutated patients. These patients are the ones who actually fell into that favorable risk group, but they can't always receive intensive chemotherapy. The great news is they generally respond very well to any treatment we give them. But there also is a completely new group of drugs that we're being able to offer for NPM1 mutated patients called menin inhibitors, which I'm going to go through here in a few slides. So I guess the most important takeaway from this slide, you didn't hear me really talk about transplant all that much. Only in one kind of group of patients, and that would be the core binding factors who can't receive intensive chemo, would we absolutely have to give a transplant to, if you will. So there are many scenarios where if you don't qualify for a transplant, we try to use our less intensive treatments and we try to use our targeted agents in such a way where we can get extended survival, achieve remission, and then it's our job as your physician to work with you to try to make these regimens tolerable long term. Many of you may have been on these things for a long time already, and you know that it gets exhausting. Sometimes you're still transfusion dependent. Sometimes you still get admitted to the hospital with infections. So it's our job to sort of personalize these regimens for you to make your life livable, right? So I'm just going to go through briefly some of the survival curves. I know that's not so important to you as a patient per se, but I think it's important to put into context what we are telling you when we meet you. So the big one is the VIALE-8 trial, which was looking at azacitidine and venetoclax. And just high level, when you're looking at a slide like this, we look at these survival plots. So this is the likelihood that you would be alive at this time point, right? If you're a patient who was randomized to azacitidine plus venetoclax, these were patients with a median age, I think, of around 76 years old. So older patients. And remember, our original standard of care was azacitidine. So that's what our comparator arm was. It was a 2-to-1 randomization. So about 286 people received azacitidine and venetoclax compared to azacitidine alone. And there was a great survival benefit to those who had venetoclax added to their regimen. And, you know, this is all very relative. If I told you that the survival of these patients who received azacitidine and venetoclax was 14 months, well, you would say, well, that doesn't seem very long. I want to live a long time. Well, the good news is that we have long-term follow-up data. And for patients who had a remission and continued to respond, that survival extends, right? So it's closer to 2 years, right? And every individual person, we have to think about what you're dealing with, what things you've got going on to be able to give you insight into how long we expect that you're going to tolerate this regimen or how long we want to have you on it. Like I said, I have some patients who've been on this regimen for years, and I don't promise that to everyone, but the only way we know if it's going to be you is if we try. And if we can't give someone a transplant or a patient doesn't want a transplant, it's our job to do our best with what we have to try to get that leukemia to go away and stay away. This is the oral azacitidine trial. So this is the Quasar study. This one's a little interesting because this is patients, and I don't see patients like this very often. This is patients who were over 55 who did receive that intense chemotherapy, but for whatever reason couldn't go on to transplantation or couldn't get just consolidative therapy that would cure them. So they went on to receive this pill of azacitidine, and it showed that patients had a much longer survival and they could be on the drug for 5 years. That's basically how long this study went. So some patients were on for 5 years or longer. You can see that the survival was 24 months in those who stayed on the oral azacitidine versus basically a placebo arm. The survival is still very good. Of course, what does that mean? What does good survival mean? If you want to live forever, 2 years feels short, but this is great news. This is patients who could not go on to transplantation. This is an option for patients who cannot be transplanted. And this is an option that we should think very heavily about. The way that we utilize this in practice, because it's very rare that we find a patient who gets intensive chemotherapy and can't go on to transplant. We actually can consider this for patients even who get a remission with less intensive chemo. We could potentially put them on a maintenance azacitidine as opposed to continuing azacitidine and venetoclax indefinitely month after month. We could potentially consider putting you on oral azacitidine and seeing if that will hold your remission. Okay, so it's important to keep in mind that this may be something that would benefit you if you don't qualify for transplantation. This is actually a study where they're combining that oral azacitidine strategy with venetoclax. So the best of both worlds, right? This is a study that was designed in a similar way. So patients who are a little bit older, but not, over 55, who had intensive chemo, and then they could go on to get oral azacitidine and oral venetoclax as maintenance. The regimen is a little bit different than how we would give treatment dose venetoclax. This is more of a maintenance dose venetoclax, and more to come on this. I have no results from this study. I just know that the study is completed enrollment and we are awaiting results. This may sort of overcome just oral azacitidine and may be a great option for patients. I think it'll be a fantastic option actually for patients who are on the infusional azacitidine and venetoclax to maybe switch over for long-term maintenance of their leukemia. And then this is briefly going through one of the FLT3 inhibitor trials. So this was the quizartinib trial, the Quantum First trial. And the reason I'm sharing this slide with you is because they addressed patients who went on to transplant and they addressed patients who didn't go on to transplant. And importantly, although the quizartinib could be given after transplantation, remember this is a pill, it's a FLT3 inhibitor, patients could either go on to transplant after they received their intensive chemo with a FLT3 inhibitor. If they went on to transplant, they could go ahead and get the quizartinib maintenance for up to 3 years. And then for patients who didn't go to transplantation, they also could stay on maintenance quizartinib for 3 years. Although we're not comparing these two curves to each other, right? The patients who went on to transplant had a higher survival. We know this because transplant increases survival in these patients. But if you look at the patients who did not receive transplantation, they had a much better survival with the maintenance quizartinib. And this is way better than the placebo, right? So for patients who didn't get a FLT3 inhibitor. So this actually allowed for approval of maintenance quizartinib. So you could take the FLT3 inhibitor for 3 years, and this has now gone into the NCCN guidelines. So maintenance therapy is really important. If you can't get a transplant, there must be a way to maintain your remission. So either you're going to stay on intensive or indefinite, less intensive chemotherapy, or you're going to be switched to a maintenance regimen. So if you ignore the middle part here, post-allogeneic transplant, and you look at those patients who don't have that core binding factor, couldn't go on to transplant, we should be offering you maintenance with oral azacitidine or even infusional azacitidine. And we would continue it for as long as it's helping you. The oral azacitidine is given 14 days every month. It's generally well tolerated. There are some GI side effects, some stomach upset, sometimes diarrhea, but I find that patients do very well with it. And then if you look down for patients with a history of a FLT3 mutation, again, you now have quizartinib as a maintenance strategy. So it doesn't really matter how you get into remission. We do want to get you into remission. Remember, achieve the first goal. But once you're there, we can talk about potentially just giving you a pill to maintain it and not having to go on to a transplant. This is just a slide, very busy because this is showing you responses for patients on this clinical trial. But this is the next sort of group of drugs that's going to be approved in AML. And it's really important because we have the NPM1 mutated patients, which fall into the favorable risk group. But we also have this adverse risk group of patients with KMT2A rearrangements. So these are patients who typically have a therapy-related AML and are just known to not have great outcomes. The menin inhibitors are going to change the game for the KMT2A rearranged. We're expecting approval of a single agent menin inhibitor for folks with relapse refractory KMT2A. And anytime we have an agent that's approved all by itself in that setting, we know that it too could be utilized as a maintenance therapy, right? So kind of keep this in mind. If this is you, this might be an option for you going forward. And I wanted to make sure it was highlighted here. So just kind of briefly, what other options are there? I mentioned the treatment-free remission. So if you're someone who's on azacitidine venetoclax and you've had a response for, I don't know, a year, 2 years, it might be reasonable to try coming off of it and seeing what happens. We don't have a lot of data to guide that though. So you're kind of off on an island by yourself, but I'm willing to go there with patients because I have the ability to put them back on it if they don't continue their remission. But it's something to consider. You really have to readdress your life priorities at many points along the way. And sometimes your goals and priorities change. So that should be an ongoing and fluid discussion with your physician. And then we have clinical trials. The honest truth is that most of our clinical trials are designed for folks older than 60, and they're usually in a setting where intensive treatment is really hard to offer. So you might find a trial that works for you, and most of our trials are intended for indefinite treatment and often are looking at maintenance. We also have the MyeloMatch study. This is a study that's being run out of the National Cancer Institute. It includes all of our kind of governing consortium clinical trial networks, the Alliance, SWOG, ECOG, ACRIN. And there is an older adult working group there is an older adult basket group of trials. And so basically there's a master screening protocol. And if you're a certain age with a certain AML, you get offered a certain trial treatment. So it's really designed to be a personalized trial schema. So it is something that you could ask about. Most of the trials that are designed are intended not to go on to transplantation. So just kind of keep that in mind. If you don't qualify for a transplant, there should be some clinical trials that might be considered for you. And then wildly important is supportive care. Supportive care should be top line, no matter if you're on treatment, not on treatment, going to transplant, not going to transplant. Supportive care is what's really improved survival in AML, in addition to the many approved agents now. But supportive care was all we had before we had all these agents. So transfusion support should be well considered. Your prophylactic antibiotics. I like to include palliative care because although there's not a ton of physical pain, if you will, although there can be with AML, there's a lot of psychosocial pain, distress that should be us. We should have assistance from our palliative care colleagues to help manage that as best we can. And then support groups, things like, HealthTree, to learn about your disease, to learn about what the options are. I think that goes a long way. And just as a final slide, this is the AML 5-year survival over time. There have been major improvements. Of course, I did not cover the major improvements in transplants with it, which has helped with this. And if you look at the number itself, you're like, oh, 35% 5-year survival. That's not great. I want it to be 90%. I totally understand that. But look at how far we've come. Like, look at how far it has come. This gives me a little bit of hope when I come to work every day. And my job, like I said, is to approach each individual person and their disease journey. I believe that every AML is unique. And I think that's where I get the passion points of my job, is being able to meet people where they are and help them find that strategy going forward, whether it's transplant, not transplant. Everybody's life situation is different. I've got some patients who don't even accept transfusions, but we can keep them alive and sometimes with quality, even without that. So in conclusion, first thing is, do you actually not qualify for a transplant, or do you? I wouldn't want to hold that over anyone's head. You need to establish your treatment goals with your team. Outcomes with AML are improving. Supportive care is improving. Quality of life should be priority and discussed often. And we just have a lot more to learn. There's a lot of progress ahead, and don't count out clinical trials. They can go a long way for you as well. And yeah, that's what I've got.
Thank you so much for this whole presentation and for how you addressed this topic. I think it very well answered a lot of questions. And now we're going to open it up for any additional questions. So if you have any questions about treatment options or anything to do with what Dr. Ragon talked about, now is your time to ask. This time is specifically set aside for community members to have the chance to talk to our presenters. So please feel free to ask questions if you have any. As a reminder, you can ask your question by typing it in the chat or by raising your hand if you want to ask your question verbally. If you do want to ask it verbally, once you raise your hand and we call on you, you can unmute yourself to ask the question. So we do already have one question in, and the question is, it came in while you were talking about the different clinical trials. Are these treatment options being used outside of blood cancer centers of excellence?
Yeah, I think that's a really important question. One of our goals as leukemia physicians, it's pretty hard because leukemia is, a relatively rare cancer, and perhaps there's some bias as subspecialists just wanting to have ownership over this. But we understand that access to care and access to that quality care is a big part of what we do and a big challenge in getting people the treatments that we feel they might benefit from. So MyeloMatch is trying to expand access. And we here at LCI, access is a big part of what we think about. So we have a lot of peripheral sites with some community partners where we try to get you treatment where you live, right? Because that's a big part. You heard me say that AML, it's a journey, man. It's a full-time job, and having to travel to a center of excellence, if you will, is so challenging. And in fact, I mean, just personally, the reason I came to Charlotte and to LCI is because I did my training out in Houston at MD Anderson, kind of a mecca of leukemia care. But there was nothing that made me kind of more upset than meeting a person from South Carolina or North Carolina that had to travel to Houston to get care at the most vulnerable time in their life. So in terms of the MyeloMatch study, I think there are going to be efforts to try to get sub-studies opened at some of our peripheral centers in some of our centers of excellence, if you will. But in terms of the general offerings, right, the azacitidine, the venetoclax, azacitidine with enasidenib or ivosidenib, the more we can make these things translate to centers closer to you, the better. So the more oral options that we have, the better. So we are definitely improving access with those things, but the actual management, I think it's important to have a leukemia subspecialist in the mix to help guide some of these community partners. That can be challenging in some networks, but I can tell you that most leukemia physicians are always available and open to an email, a phone call to help walk people through what it looks like to manage some of these long-term indefinite treatments. And then the other piece is the supportive care can be really tough. So if you're somebody who needs your labs checked 2 times a week and you need transfusions, we recognize that that's not easy. And that's not easy for some centers that are rural or, don't have that volume of blood cancer patients. But that's part of our job, is to try to extend that reach, to try to be here to support those physicians and those offices, that the places where you live, right? Someday, I hope that AML care will be able to be extended better out into the community. And, that's super important for folks who can't go to transplant. But it's also important for folks who can go to transplant, because that's one of the reasons sometimes why people can't go to transplant. It's because they live too far away. So yeah, we try to extend our clinical trials out into the periphery as much as possible, but I can't say that for every center that exists, but it is something that we are aware of and are working hard to try to get access to.
Thank you for that answer. I think that's a huge, like you've mentioned several times, the different types of access that limit care or make care more difficult for patients. And so I mean, myself, I'm grateful that you are doing the work that you're doing in order to help mitigate that issue. But kind of going back to that issue you brought up at the very beginning on access to transplant, if someone has been told no, and they maybe didn't get a second opinion or they haven't done anything like that and they're questioning, maybe it is an issue of access, or maybe I might qualify, what kinds of questions should they bring up to their doctor to make sure that is true for their specific AML?
Yeah, that's a great question. And I think everybody's situation is really unique, because sometimes there may be really clear reasons why a transplant can't be offered. You know, it's really clear to me when a patient is 85 years old and they show up and I say, unfortunately, we won't be able to offer a transplant, but sometimes there's freedom in not being able to do that, because then we can just focus on what can we do with the options that we have. Or at least I find a lot of freedom in that. The times that it's really challenging is kind of hanging transplant over somebody's head a little bit, and saying, well, maybe we can, if we can get you a little fitter, maybe we can do this. But once a decision is made, like you can or you can't, there can be freedom in that, right? Then you restructure your goals and you move on. So for patients who aren't quite sure if they really aren't eligible for transplant, and it is a fluid thing, like sometimes you're not eligible, but then something changes and you are. And it's hard to address every individual factor. I would say, you know, as transplanters, we're trying to understand, how do we assess somebody's eligibility for a transplant? So there's a big study called the CHARM study, which is assessing various factors, including frailty, fitness, social structures, disease structures, that's trying to tell us who are the patients who actually should be eligible, patients who previously might not have been offered a transplant who should have been or should be. So as transplanters, we're learning more about that. And so that's why I think it's really important, especially in the current era, as that data evolves and as transplants evolve, I would always be circling back and ensuring that it is a no. Um, and I don't know too much about, like, you know, seeking many different opinions. I mean, some patients, I welcome to do that. We don't often say no, but when we do, we always say, you know, we might say no, but another center might say yes. So feel free, I can, you know, connect you with so-and-so here. If it's important to you to be sure, then please go have another opinion about it. I would definitely encourage people to do that, but resources are tight. Resources are not always available for that. Um, and it's a little bit different too, since I'm a leukemia physician and a transplanter. It's kind of a conversation that's always ongoing. So, you know, if I told you, no, I don't think a transplant is in your best interest, but 3 months later you still think it is, I'll have the conversation again. Wherever you are at that point, we'll have it again and we'll decide at that point, is it right for you or is it not? That's a little tougher when the departments are separated. But I don't think anybody would refuse you if you wanted to go back and talk to the transplant physician, but you just have to have an open and honest conversation with whoever's treating you. Because the most important part, well, one of the most important things about the treatment journey as AML is you have to have peace about your journey. You have to be all in on whatever path you take. So you have to understand why we're doing what we're doing. You have to understand when we say no. You have to understand why we say yes. Without that sort of piece in the plan, I find that there's a lot of trouble along the way. In, you know, getting to the place of peace in the plan can take time. But if you don't have peace in your plan, go find it. You know, reach out to support groups. Try to understand why you don't have peace in the plan that is available for you. I think that it's important to lean into that, because it's, for me at least, taking care of people with this. I think it's wildly important that we're all on the same page, that there's that level of trust. Because if you're not sure of the plan that's set out for you, there's going to be an element of distrust somewhere in there. And you got to do a lot of trusting with this disease because it's not easy. So I'd say, you know, go find peace in your plan, go find a physician or a provider you can trust. And, you know, take it as far as you need to. Like, it's not going to hurt our feelings. We want you to be comfortable with the plans that we set out. And sometimes we don't have great news to share. Most of what I share with people is not good news. But even in the bad news, reprioritize, readdress your goals, and figure out a plan forward, you know?
I love what you brought up about peace in the plan. I think making sure, you know, if this isn't something that you feel confident in that decision, ask, get as much clarity as you can about why transplant might not be a great option or what would what would change that later. Are there things you're looking for, things like that, making sure that you feel comfortable and confident. I loved that. Thank you.
Yeah, I try to use that often because we don't get a lot of peace when it comes to AML, but if you don't feel comfortable in your treatment journey, it's just so hard. Like it's hard enough as it is. So you want to feel that you can trust the plan that's in front of you, even if it's not easy. You have to take those steps to understand it. And it's our job to help you understand. And if you don't understand, that's our fault. We need to help you. So
And then at the end, you brought up palliative care as an important part. Do you want to share maybe a little bit of what those kind of options are? I think palliative care is often misunderstood or not really understood what it can do to aid in a patient's treatment.
yeah, and sometimes I refer to it as supportive oncology as opposed to palliative care, although I don't really see palliation as a negative thing. I can understand how they've been kind of linked together with the hospice philosophy, which that's different, a little bit different than palliative care, although it's along a spectrum. So palliative care is supportive oncology. They can help us with pain symptoms. They can help us with nausea symptoms, all those symptoms that people develop. But most importantly, at least in our practice, it's the psychosocial distress that they can help with the most. So our psychologists that operate under supportive oncology, our psychiatrists, the support group, some of the more integrative health philosophies fall under palliative care or supportive oncology. And what we know is patients who are involved in palliative care, not necessarily hospice care, but palliative care, have a longer survival than those that don't. So for us to not be offering it as a part of the whole of AML care, especially for a patient who cannot get that curative, as we say, curative, and it's potential for a cure. It's not always a cure. If you can't offer them a cure, we need to offer them all the things that could help improve their life quality. For me, it's the sort of psychologic distress that is just not. I can only do so much in my practice for patients, so I try to get them access to all of it. Someone who can have the longer conversation, the longer sort of cognitive behavioral therapy when you can't quite get past the distress of having AML. Palliative care is a big key in that. And I think it's a part that's often overlooked, but I think it goes a long way. And more of our clinical trials are starting to address these patient-reported outcomes and sort of health quality. And so I think palliative care has a big role in that. Not every center is equipped for that. Some of those community centers may not have the access for features like that. So if you do have access to them, I would ask about them.
And then we had another question come in, kind of a specific to situation question. So they listed some of their mutations,
Yeah,
NRAS and EZH2 mutations. Any other new
yeah.
targeted treatments for these? They clarified post-transplant 160 days, doing okay, worried about relapse, 47
Yeah.
with no other conditions.
And so I think this is one I was curious if we were going to get a person who was worried about relapse post-transplant, because one of the times that people may not qualify or are not interested in another transplant is when they've already had a transplant. So that's a big group of patients that I think the psychosocial distress of the idea of the disease coming back is very worrisome. So in terms of the question about NRAS and EZH2 specifically, so there was a time where we had these histone deacetylase inhibitors, so these histone modifiers that were working directly on EZH2. I think we'll see those kind of come back into the mix of treatments at some point. And essentially all the drugs that we're currently studying, we're really focusing on some of the more adverse risk groups, and EZH2 kind of falls into that a little bit. And so we're just trying to nail down whether these drugs actually target. So instead of coming from EZH2 to the target, actually taking the targets which are more global and walking it back to see if they benefit the EZH2 mutated patients. It also falls into a group of maybe secondary AML, so this kind of class of patients where we do have the CPX drugs, and venetoclax has been shown to be helpful for those patients as well. So I'm congratulating you on being 160 days post-transplant with that phenotype of disease. I bet you're going to do great, actually. And the fact that you're young, you have plenty of options available should your disease come back. It probably won't, but if it does, the fact that you had a transplant, there's a lot of things that we can do to help boost the immune sort of effect of the transplant that you had. But in terms of clinical trials, I think, there's many coming. There's no slam dunks. The menin inhibitors are the biggest slam dunk that's coming this year. But I mean, these things change. They can change after a year. We're working in the arginine pathway right now. We have a clinical trial that seems to be hitting some of our more adverse risk patients. We're really excited about it, and hoping to move that forward. So it sounds like you're doing really well right now. So lean into that, lean into it wholly, you know, try to have gratitude in the days that you're not thinking about it. And know that we're working hard to find ways if relapse is ahead, and hopefully it's not.
Yeah, I'm glad we got to address that, more unique situation. So thank you for your responses there. Um, that is the time we have for questions today. So thank you everyone for joining and for participating. If you have questions that you can't think of now, if you come up with them later, feel free to message them to me and we can make sure we get your questions answered. Before we go, I wanted to talk about something that is one of our features in Cure Hub that I think relates really well to what we were just talking about. And that's our features for clinical trials and treatment options. So once you've connected your medical records in HealthTree Cure Hub, you can start exploring ongoing clinical trials, treatment options that are available for AML patients. This information can help you to make informed decisions in important conversations with your doctor. On the screen, I have the link up for HealthTree Cure Hub along with the email address for our patient navigators who are able to help you create an account and connect your records. I'll also include all of this information in HealthTree Cure Hub in our follow-up email so you can look for that there. We have some events coming up in September that I'm excited about. So on Monday, September 24th, another thing we kind of talked about a little bit, I'm going to be hosting a roundtable on community clinics and academic centers working together for best patient outcomes. So for this, we're going to have a panel that includes a hematologist from an academic center, as well as two oncologists from the community setting, where it's going to be a more discussion-based event. We talk about the power of involving both academic and community clinics in your care. So please feel free to email me any questions you have on this topic ahead of time, or you can join live to ask your questions during the Q&A. As you all know, September is Blood Cancer Awareness Month, and so we are hosting a special webinar at the end of September, hosted by our HealthTree founder and CEO, Jenny Ahlstrom, who'll be presenting on innovation in blood cancers. So we're going to bring on specialists from each major division of hematology, multiple myeloma, leukemia, lymphoma, and MPNs to share highlights of the most exciting things happening in their field. And then on Tuesday, October 1st, we're going to be having a webinar on Medicare changes for 2025. So that's another one that's going to be very informational and will be a great resource. So as you can see, September is packed full of opportunities to learn. You can go to the link on the screen relevant to your disease and you can sign up for all of those events. As a reminder, we're going to have a 2 to 3 minute survey that comes up after we leave this call. On that, you're just going to be asked thoughts on today's webinar and then any feedback we can have to make future webinars better. And then you're given a chance to submit topics that you would like to see us cover in future topics or in future webinars. I again want to thank AbbVie, our HealthTree for AML sponsor, who helps to make events like this possible. And then finally, I just wanted to say thank you all for joining and for helping us build our AML community. I've added my email to this slide, so please don't hesitate to reach out if you have any questions about HealthTree, any of our programs, or have any feedback you'd like to share. I appreciate you all, and I hope everyone has a great rest of their day, and then I hope to see you all at an event coming up soon.